PDA short case. Examine the precordium and tell your findings. On examination of precordium of this young girl reveals chest deformity is present. There is visible pulsation in apical and suprasternal area. Apex is situated in left sixth intercostal space, lateral to the left mid-clavicular line, forceful but ill-sustained. There is a continuous thrill on the left upper parasternal area. There is a continuous missionary murmur at left upper parasternal area, which is of grade 4/6, having no radiation, which starts after S1, loudest at the end systole and the beginning of diastole, continuous through S2 and S2 merge with the murmur, having multiple clicks. So, what is your diagnosis? Persistent patent ductus arteriosus. What are the differentials? Aortopulmonary window VSD with AR, ruptured sinus of Valsalva. How to differentiate them? In aortopulmonary window, clinically indistinguishable from PDA. In epi window, murmur in the left third intercostal space, lower and midline, mostly systolic murmur, not continuous like PDA. In case of ruptured sinus of Valsalva, usual presentation is acute and severe. Murmur at mid to lower sternal border, diastolic component is prominent, more intensity 5 to 6/6, characteristically superficial quality, VSD with AR. Thrill at lower parasternal area, soft A to harsh pansystolic and blowing early diastolic. What are the other causes of continuous murmur? Aortopulmonary window, VSD with AR, ruptured sinus of Valsalva, coronary AB fistula, venous hum, BT shunt, TOF with rich collaterals, MR with AR, AS with AR. What are the types of PDA? Krichenko angiographic classification reveals there are 5 types of PDA. Type A, B, C, D, E. Type A is conical shaped, 65% most common. Type B, window shaped. Type C, tubular. Type D, oval or complex. Type E, elongated. Hemodynamic classification. Small PDA means when QPQS ratio is less than 1.5:1. Moderate means when it is between 1.5 to 2, and LA/LV dilated, pulmonary artery pressure normal or mildly elevated. Large PDA means when QPQS ratio is more than 2:1, LA/LV dilated, pulmonary artery pressure elevated. What is the cause of this lesion? What history you need to know from mother? Maternal rubella, maternal rash in first trimester, prematurity, high altitude, Down syndrome, Edwards syndrome, Char syndrome. What are the other associate lesions we need to look for? We need to look for coarctation of aorta, ASD, VSD, atrioventricular septal defect or AB canal defect, bicuspid aortic valve. What are the PDA dependent conditions? Both duct dependent pulmonary and systolic flow are TGA. Duct dependent pulmonary flow are tricuspid atresia, pulmonary atresia, TOF with severe pulmonary stenosis, critical pulmonary stenosis. Duct dependent systemic flow are critical aortic stenosis, severe coarctation of aorta, interrupted aortic arch, hypoplastic left heart syndrome. Now, what are the different clinical presentation of patient with PDA? At birth, no symptom because high pulmonary vascular resistance, minimal left to right shunt. After 6 to 8 weeks, as pulmonary vascular resistance falls, symptoms start. Pulmonary arterial hypertension starts to develop. With time, PVR rises, pulmonary vascular obstructive disease develops, and right heart failure occurs. Usual presentation is asymptomatic incidental murmur first few years of life according to size of duct. failure to thrive and growth retardation, repeated chest infection, bronchopneumonia, angina, feature of heart failure, syndromic presentation. What are the precordial findings? Apex shifted, forceful and ill-sustained, continuous thrill in the left upper parasternal area below clavicle. A continuous machinery murmur which starts after S1, loudest at the end systole and the beginning of diastole, continuous through S2 or second heart sound, and S2 merge with the murmur having multiple clicks. Mid diastolic murmur at apical area if large PDA. What are the relevant findings from general examination? High volume collapsing pulse, wide pulse pressure, pulsation at suprasternal notch. What are the clinical features of shunt reversal symptoms? Angina, syncope, dyspnea, hemoptysis. Signs are differential cyanosis and clubbing. SPOT upper limit normal, lower limit less than 90%. Left parasternal heave, single S2 loud P2. Gibson and MDM disappears. Short systolic murmur, absence of murmur, Graham still murmur. What are the other name of Gibson murmur or continuous murmur? The other names are machinery murmur, cartwheel murmur, humming top murmur, train in tunnel, mill wheel murmur. Why murmur is loudest at the end of systole? At that time, pressure difference is highest between aorta and pulmonary artery. When ductus closes after birth, functional within 3 hours and anatomical within 3 weeks. So, when ductus closes after birth, functionally closes within 3 hours and anatomically closes within 3 weeks. Why there is collapsing pulse in PDA? Rapid run of aortic blood into low pressure pulmonary circulation. Why there is wide pulse pressure in case of PDA? Increased preload causes increased stroke volume, so aortic systolic pressure rises. Diastolic pressure is lower due to a diastolic runoff of blood into PA. So diastolic pressure is lower due to diastolic run of blood into pulmonary artery. So diastolic pressure is lower due to diastolic run of blood into pulmonary artery. What are the X-ray findings in PDA? The X-ray findings may be normal, cardiomegaly, LB type apex, LA enlargement, prominent aortic knuckle, dilated pulmonary artery, calcified ducts, plethoric lung field. Peripheral pruning if increased PVR and pulmonary hypertension, notching between aortic knob and pulmonary trunk, figure of 3. What are the ECG findings? LV hypertrophy due to volume overload, tall R and deep Q in V5 and V6, LA enlargement, bifid and wide P in lead 2. RB hypertrophy, pulmonary hypertension, atrial fibrillation rarely. What are the information you get from echo? Visualize PDA and measuring the size. Assess hemodynamic significance, chamber dimensions, direction of shunt, magnitude of shunt, PVR, degree of pulmonary hypertension, pulmonary artery systolic pressure and mean and diastolic pressure. What are the echo views to visualize PDA? Left parasternal short axis view at base of heart, high left parasternal view, that is ductal view, suprasternal long axis view, modified plaques view. Mention the echo finding in PDA. In plaques view, LV-LA enlarged, visualize PDA measuring its size from ductal view at its narrowest point before entry into a major pulmonary artery. Less than 1.5 mm small, 1.5 to 3 mm moderate, more than 3 mm large. LV systolic function. Parasternal short axis view reveals dilated major pulmonary artery due to ductal flow regurgitation into pulmonary artery. Evidence of pulmonary valve prolapse as ductal regurgitation flow repeatedly hits the pulmonary valve. Colored Doppler echo, pulmonary regurgitation jet on color flow mapping in parasternal short axis view shows retrograde mosaic jet from descending aorta to major pulmonary artery, On pulsed wave Doppler with the sample volume placed in pulmonary artery, a positive flow signal is detected in diastole retrograde flow, and with the sample volume placed distally, a sudden increase in systolic flow velocity is detected at or just beyond the level of ductus. On continuous wave Doppler, left to right PDA shunt, continuous positive flow with a peak velocity in late systole, sawtooth or picket fence appearance, sawtooth fencing pattern or sawtooth pattern. Right to left PDA, continuous negative flow with a peak velocity in early systole, bidirectional shunt right to left in early systole and left to right shunt in late systole extending to late diastole. Quantification of magnitude of shunt. The pulmonary blood flow QP and the systemic blood flow QS and their ratio QP/QS can be calculated from 2D and colored Doppler examination. PVR 10 into PVR pulmonary vascular resistance equal to 10 into TRV divided by RVOT TVI plus 0.16. Measurement of pulmonary arterial systolic pressure, mean pulmonary artery pressure, pulmonary artery and diastolic pressure. What is the purpose of cardiac cath? To do catheter trajectory, oximetry run, pressure study, angiography, LV-graphy to see associated VSD, aortography to see coarctation of aorta. So, what is the purpose of cardiac cath? They are catheter trajectory, oximetry run, pressure study, angiography, LV-graphy to see associated VSD, aortography to see coarctation of aorta. What is finding in catheter trajectory? Catheter easily pass from pulmonary artery to aorta through PDA, giving a hairpin appearance. So, catheter easily pass from pulmonary artery to aorta through PDA, giving a hairpin appearance. What are the differentials of oxygen step up in pulmonary artery? Aortopulmonary septal defect, sinus of Valsalva up rupturing into pulmonary artery, aberrant left coronary artery arising from pulmonary artery with reversal flow. What are the treatment modalities for PDA? Medical management includes indomethacin if prematurity, prophylaxis of infective endocarditis, treatment of heart failure. Intervention includes coils, Jan-Turco coil device, enlarged duct occluder. So, coils are Jan-Turco coil, device name is enlarged duct occluder. Surgical ligations. Indication for closure of PDA. All PDA should be closed unless contraindicated. Timing for closure 6 to 12 months of age or weight more than 10 kg, transcatheter occlusion. 3 to 4 years surgical occlusion. So, when will you close the PDA? In case of 6 to 12 months of age or more than 10 kg weight, transcatheter occlusion. In case of 3 to 4 years old child, it may be surgical. When coiling is done, when the duct is very small, less than 1.5 millimeter. So, when coiling is done, when the duct is very small, that is less than 1.5 millimeter. When surgery is indicated, PDA is too large, technically not suitable for device closure, distorted anatomy, precludes aneurysm and arteritis. Contraindication for closure, Eisenmenger syndrome, irreversible pulmonary vascular obstructive disease, associated duct dependent congenital anomalies. So, associated duct dependent congenital anomalies. Complications of PDA includes infective and arteritis of PDA, pulmonary hypertension, Eisenmenger syndrome, CCF, pulmonary vascular obstructive disease, mycotic aneurysm. Now, natural history of PDA. Ductus arteriosus is usually closed functionally within few hours after birth, usually within 3 hours, maximum 18 hours due to inhibition of prostaglandin E1. Anatomical closure takes place within 2 to 3 weeks after birth. Spontaneous closure is unlikely after 2 years. Less than 10% develops Eisenmenger with shunt reversal after 15 years. Life expectancy half of the normal. Thank you.